All right, folks, welcome to the session. So I'm just going to take you through a brief introduction. A lot of this is going to be thinking about psychiatric illnesses, and then there's a little bit about psychopharmacology at the end. So what I'd like to do is just begin by thinking about what mental illnesses are. And what they are a set of complex heterogeneous illnesses that affect various higher brain functions. And these higher brain functions include things like creating a model of the body and the world, memory, enjoyment, mood, emotional reactivity, and so on. And by and large, mental illnesses aren't associated with gross brain pathology. And where we've sort of identified pathology, it usually tends to be quite distributed rather than localized. And thus far, we don't really have any neuropathological markers that are useful at the single subject level. They're mainly at the sort of group level. And here we're talking about findings on structural and functional imaging in particular. So it's perhaps best to think about them as dysfunctions of brain networks that result in impairments of these higher brain functions, thus causing impairments in functioning and or causing distress. Okay, now, most of you are probably familiar with this from your psychiatry rotations in med school and so on, that we define mental illnesses in terms of descriptive syndrome. So it's a very phenotypic approach. And then those descriptive syndromes are further qualified by functional impairment and subjective distress. And I'm going to illustrate with the model of major depressive disorder. So this is the DSM-5 criteria for major depressive disorder, and you have this set of symptoms. And to make the diagnosis, what you need to do is have about 5 of these symptoms for a 2-week period, and one of them should be depressed mood or anhedonia. And taking that construct with a set of those features, we make a diagnosis of depression. But one thing you've got to remember about this phenotypic approach is the phenotypic approach is very much an observational cross-sectional approach in some ways. It is agnostic to any kind of mechanism or process underlying it. And even at this level, it sort of illustrates the tremendous heterogeneity in the conditions we deal with. Now, Eiko Fried has done some very interesting work showing that, even looking just at the phenotypic level, you can qualify for a diagnosis of depression in about 216 different ways. And some of those different ways are very, very different from each other. So this is just an introduction to heterogeneity as being a core part of what we deal with in psychiatry. There is a lot of variability in presentations. Okay, so I'm going to sort of suggest a particular approach to thinking about clinical evaluation more generally, and then more specifically for psychiatry. So we can think about the process of clinical evaluation as a sort of data collection exercise, right? So you take a history from somebody, you get a set of data points there, and then you do an examination or investigations, and you get some more data points. And what you're trying to do is essentially infer what is the illness process that has led to these data points that you have been able to collect. So to illustrate, if you have a set of data points like this, you could infer that the cause for that data set that you have collected might be a pneumonia, and that would further point to other findings or other data that you would expect. Okay, this is a little bit of a cartoon example just to illustrate the process. But in reality, what happens is that we have data points or data that are of different magnitude and different precision. And by magnitude, I mean actually how large that particular signal is. And precision is how specific it might be to a particular condition. So for example, fatigue may be a very high magnitude symptom in that it is a very, very strong data in a particular individual, but it can be relatively non-precise in terms of telling you what the underlying process might be. Okay, So the steps of the evaluation or exercise are you detect and collect the data points, you weight them, and then you infer what the likely causes of the data are by either some process of pattern recognition or using a model of the generating process. And by that, I mean thinking about what might have led to this, okay? How different are these? These may not be very different, and they are less different the better you have an understanding of the pathway from the process to the phenotypic data that you get. So in areas of medicine where we've got a very good understanding of etiology and pathophysiology, in a sense, the difference between a kind of pattern recognition and a model-based sort of approach to thinking about diagnosis or evaluation may not be all that different. But if you don't have a very clearly specified etiology or pathophysiology, or if you've got processes in which there are multiple pathophysiological mechanisms that may lead to the same kind of presentation, then it's perhaps more useful to think about this using some kind of model that generates this data that you're seeing, okay? And in terms of whether it makes a difference whether you do it, entirely depends on what purpose you want to use that for, okay? So when we're thinking about a pattern recognition type approach, it's something like this. There's a particular pattern that connects these different data points, and as part of that pattern, you might expect to see additional things that you would then go and look for. And if you're using a model, you could be thinking about some process that generates that. And if you're thinking about a particular process that may have given rise to data points x1 to x10, then that process would also indicate that you should look for the additional data points of 11 and 12. Okay. The reason I sort of just belabor this is that in psychiatry, we've got a particular challenge, which is that for a lot of our conditions and for a lot of the phenomena we study, the underlying physiology, so to speak, of these complex mental functions is something that we don't have fully specified. And thinking about disturbances of these processes in terms of an equivalent of pathophysiology is very variable across different processes we know. And again, it is not possible to really argue that we have a complete pathophysiological process for most of the conditions and phenomena that we deal with. So what that means is that in thinking about psychiatric conditions, you often have to work with models of multiple processes that may be going on. Okay, so here I'm just going to take a slight step aside to think about the sort of data we routinely collect in clinical encounters in psychiatry. And there are some ways in which I think what we do does differ from what one does in a lot of other medical specialties. Depending on specialty. But broadly, one can think about the data we sort of collect in terms of sort of story data, where we are gathering the content of people's stories, what happened and when. And of course, because we're interested in people's life courses and the longitudinal antecedents of their illness, we are interested in looking really across the life story, truly across the lifespan, not just the current episode of illness. But in addition to the actual content of people's stories, you're also very interested in the structure of people's stories. How are they able to tell their stories? Normally, we tend to expect a certain linearity. People can tell you stuff in a chronological way of what's happened to them, what they've been through, and in a fairly continuous way. But there are lots of people we encounter who aren't able to do that, who aren't actually able to give you linear, continuous narratives of their story. And that gives you vital information as well as to what's happening to the person. For various reasons, difficulties, experiences they may have had, some people may only be able to give you their story in fragmented episodes with no sense of continuity of them going through a series of experiences. And for example, that's something you see quite commonly in people who've been through severe recurrent trauma. So that too is important information. And then there's a set of kind of non-story data. And one aspect here is the relational data, which is the information you're picking up in the interaction between you and the person, how they respond, react to you, and how you react and respond to them. And then there's an important bit that you're doing some of the data collection from within you, not just from the person. And of course, then there's non-relational data, which are just observations that you may make of the person. And here I would put in things like looking at abnormal movements, draw extrapyramidal symptoms, and so on. So you collect these various bits of data, and then for an individual patient, you may have to think about multiple ways of making sense of this data that you've gathered. So it may be that you see one person who's presented to you with what looks like an acute psychosis. And a model of psychosis may help you make sense of many of the things that they are either presenting with now or have recently experienced. And you could think about whether a model of an affective or a non-affective, that is a mood or a non-mood psychosis, helps make sense of some of the things that you see. But there are also be other elements that you've collected in their picture. And these may be part of their longer term story. So difficulties in relating to people, difficulties with trusting, fearful of risking, making connections with people. And some of those might be better understood in terms of a model of early life attachment and attachment styles through childhood and adulthood. Some aspects of their experience may actually be better understood in terms of a trauma model, where fear of closeness or difficulty trusting and emotional disconnection may relate to experiences of recurrent trauma. And if that's a possibility, then that would suggest that you ought to look for other things that you might expect to see in people who've gone through recurrent trauma. And then some aspects of what people present with may be related to something that's far more existential for them, that either the experience of illness or the experience of adversity has meant that it's been difficult to either establish some sense of purpose or meaning in their lives and meaningful connections with people, or the experience of illness has disrupted something that existed before and led to a kind of despair for the future in terms of how exactly does life go on after this. And here you may need to think about using a sort of more existential type thinking model. I don't present these as sort of, solid options in a sort of each person you go through, each person you meet, you go through model 1, 2, 3, 4. These are just illustrations of multiple models that you need to sort of bear in mind while trying to make sense of people's experiences and people's stories. And these multiple perspectives need to be borne in mind often simultaneously at different points in people's illnesses and their treatment. Some models may be more relevant than others. Now, one of the important bits of using the word model there is that one has to think about these in the way that one would think about hypotheses, right? These are hypotheses. As you go through someone's care and treatment, you may be able to get more and more data to support one hypothesis over the other. Okay, but we're not thinking about these as these are absolute ground truths about the person. And one of the challenges in psychiatry is learning to sort of hold that uncertainty about, I'm not quite sure what's happening here, and reconciling oneself to the fact that sometimes clarity will only emerge with time and more data. Okay, I'm going to move from that to something very different. And this is just introducing some ideas from our contemporary neuroscience into the ways we think about, into the ways we think about mental illness. And what I'd like to do is introduce this idea to those of you who have not come across it before, of the brain as a sort of predictive organ. So in this type of thing, in this type of model, we're thinking about the brain housed within a body that inhabits an environment, right? And the brain does not have any direct access to the body or the environment. It's just got electrical impulses coming through to it. And its task is to sort of figure out what exactly has led to this input that I'm receiving. I've put in a little bubble here called the mind, and this is just borrowing from an idea from Chris Frith, where he sort of thinks about the mind as our conscious experience of ourselves, because a lot of what our brain does doesn't come up to consciousness, and rightfully so, right? So you can decide you want to walk. All the complex muscle movements and joint positions that you need to go through to walk ideally shouldn't come up to conscious experience. They should just happen, okay? So now, the way the brain does all this is, we think, in a predictive manner. It's not accumulating information and then putting that together to build a model. From the moment it comes online, it is iteratively building models of the world. So it makes predictions and then updates those predictions in the light of information that comes to it, okay? Now, this is an example from visual perception to just illustrate that. For those of you who have not seen this before, this is a picture of a woman kissing a horse, okay? And it may be quite difficult to figure out which side of the picture the woman is and which side the horse is on. So I'm going to give you a little bit of help. Okay, because we're doing this on Zoom, I can't quite see whether this has worked or not. So I'm just going to repeat it once more. Okay. Hopefully, most of you should be able to now make out the woman kissing the horse in this image that you're seeing on screen right now. But importantly, nothing has changed in this image from the time you first saw it. This image remains a set of black and white patches, but what's changed is that you now have additional information that you can use to disambiguate it. You've got a prediction about what this contains that allows you to sort of make sense of it. And this is really quite a powerful process, because if you were able to see the woman kissing the horse now, then you can probably also see that this bit here is her jawline. But actually, this is a rather incomplete contour. You've just got this one line here. All this is blank space, right? But nevertheless, you can see this as her jawline. Okay, I'm going to move to another example. And this is a very famous illusion in psychology and neuroscience. It's called the hollow mask illusion. It's a hollow Charlie Chaplin mask. This is the right side, this is the inside. Now, a lot of people, in seeing this, experience that hollow side as popping out. It doesn't feel like it's caved in or concave. It's experienced as convex. This isn't universal, but for most of us, the experience is that once it's perceived as a face, the face seems to stick out. And the way we understand this is that faces stick out. That's our general experience. Faces do not cave in, and faces are biologically very, very salient stimuli. So the moment this is sort of recognized as a face, it immediately pops out like faces are expected to do. Now, when I say this is recognized as a face, it's not something that we're consciously doing. If you experience the illusion, then it's very hard to switch it off by telling yourself, no, but it actually is concave, okay? And it's just a way to illustrate how the brain establishes these higher level mods or higher level predictions about the way things are in the world, the statistical regularities in the world, to kind of make sense of incoming information. So some long-standing statistical regularities that the brain and we are all used to is, in general, light tends to come from above. So visual information is interpreted in the light of that, no pun intended. Or that gravity exists and things fall if they're not supported. Right? So those are things that are factored into our very perceptual experience of the world. Okay, so in this kind of thinking, we're thinking about the brain essentially building a model of the world and the body, and it's sort of continuously doing this in a predictive way and updating it, and there are constant inputs and outputs through this process, and it's constantly iterative. Okay, in terms of how this is implemented in the brain, this is just a cartoon to illustrate our current thinking around this, and the idea is that we have multiple levels in the neural hierarchy, and one can think about the sensory input here on the left coming into the basic sense organs, and there is a level that includes the basic, the initial nerve cell receptors and their immediate higher level projections. And the way we think this operates, that at the lowest level, you have sensory input that comes in. And from the highest level, you have predictions that are passed on. But the way it works is that each level passes on a prediction to the level below. And whatever can be predicted at a particular level is dealt with there. What is passed on to the next level is what could not be predicted here. So in a sense, the raw sensory input is sort of available at the first level, but from then on, what's passed on is each bit that's not entirely predicted, okay? Now, if you get something that's strange that happens here that hasn't been previously predicted or experienced, then there will be more of it that needs to be passed up. Okay, so in summary, each level sort of passes on a prediction to the one below and a prediction error to the level above. And in a couple of minutes, I'm going to illustrate this in the condition of psychosis. Okay, now we can think about psychosis as probably the archetypal condition in which this fundamental brain function of this fundamental brain process goes awry. If what the brain is meant to be doing is constantly building and updating its model of the world, psychosis is a process in which that model of the world is altered and people's experience of themselves and the world changes, okay? There are various symptoms that one can think about. And again, I should sort of emphasize, these are models of thinking about experiences, right? There are bits of empirical data that support different pieces of it, but this is still very much a sort of work in progress in the field. Okay, so when we think about our clinical definition of psychosis, these are really the three key things we're looking for: delusions, which are abnormal beliefs; hallucinations, which are abnormal perceptions without any corresponding percept in the real world or the shared physical reality; and thought disorder, which is mental disorganization as betrayed in speech. And if you want to make a clinical diagnosis, that's what we're essentially looking for. But one thing to bear in mind is that when we talk about delusions, hallucinations, thought disorder, this is very much thinking at the clinical phenotypic level, right? But as I mentioned with depression, the way that these processes are kind of agnostic to any kind of underlying mechanism, it's important to consider that really these represent perhaps the most striking features of this altered landscape. By the time people have got to the point of having new beliefs about the world and having unusual experiences of the world, a lot has changed to get to that point and to support those beliefs and experiences. So when you're trying to understand someone's experience of psychosis, what you really want to do is get a sense of how their experience of the world and themselves has changed from what it used to be. Okay. So this is quite helpful when you're trying to understand the development of these conditions and make diagnoses. And at some point in the development of an illness, someone's model of the world and themselves has changed in a fairly fundamental way and resulted in the development of psychosis, as one might see in, let's say, schizophrenia. But we also need to be very alive to the possibility that, this is a cartoon that's just meant to illustrate a very stark contrast, that there is a range of different experiences of the world that we find in the general population. And there are some people whose experiences of the world, if seen in cross-section, may look like very much what you're seeing on top here. But a key thing is that these are often long-standing ways in which they have experienced the world. I've missed a couple of other things here. So I've included borderline personality disorder, which is one of our very problematic diagnoses as an example here. But some other conditions that I should put here are complex PTSD, which is closely related, but also autistic spectrum disorders and the neurodiverse conditions more broadly. So people on the neurodiverse spectrum often have very, very different experiences of the world than neurotypical people do. And it's vitally important to just ask the question, look, have things always been this way? Or is this something that's different? So in terms of a clinical approach, this is a very important thing to bear in mind, that really what you're looking for more generally when you're thinking about illness is that you're interested in this process of change, what things were like before and how they have evolved to the cross-section that you're seeing at the moment, okay? But this is, of course, a little bit of a challenge, and I'll come to that in a moment. So now, with each person you're seeing, you're trying to answer two questions. What illness does this person have? And who is the person who has this illness, right? What we do quite well in medicine is that we're pretty good at teaching people how to answer the first question. How to answer the second question is something that we recognize as important, but is perhaps a bit harder to teach didactically. But it's something that you'll learn to do during your career as a clinician. So one approach I'd sort of offer for this is to think about this in terms of the task of modeling or understanding other minds, okay? So we have this classic empathy question of how would I feel if I was in this person's shoes? And that relies on two important assumptions. One, that you have an accurate reading of what it is like in this person's shoes. And two, that your mind is sufficiently similar to that person's mind for you to be able to make those inferences, right? And I say sufficiently similar, right? We don't have identical minds, but do you understand that mind enough? Is it sufficiently similar to your own for you to draw those conclusions or make those inferences, okay? Whereas really the task of empathy is, how does this person feel in their shoes? And for that, you need to have an understanding of their mind, right? Now, it isn't strictly necessary to do that. You can use some hacks. You can just use compassion, and I don't understand what it is like to be in your position, but it sounds difficult and I'll try and help. But the other way that you can get some sense is to figure out how things have changed from that person's baseline, right? So to illustrate here, at some point, people have moved from their baseline into territory that you can clearly recognize as illness, because this bit we've learned to do reasonably well, right? And we're quite good at sort of characterizing what's happening in this gray box, but it's vitally important to also understand the length of this arrow, where people were before and where they've come to now. Right, and at least that allows you kind of through a process of inferring what might have been before people reached here, right? But this is vitally important to consider always, because we often don't have a sense of where people's baseline was before they became ill, unless you're sort of actively looking for it, okay? And this is not a difficult thing to do. You can just ask about what their lives were like before, what they were doing, what they were capable of, to give you some sense of what the degree of change is, okay? And here I'm going to move on to the related idea of, let me just finish this. So a couple of things that you can do, a couple of questions you can ask, because I think this is something that's always very frustrating when you're a junior clinician, when people tell you, well, go and ask for this, and nobody tells you, but how do I ask? What's a helpful and understandable form of words to ask this question or get this information? So some helpful questions are just to ask, how and when did things start to change, or how is now different from before? Okay, so let's move to functioning, which is a sort of very closely related area, and something that's a particular bugbear of mine, because functioning is a very important metric in a lot of medicine and healthcare, It's especially important in psychiatry because since we're dealing with so many subjective phenomena, internal experiences, that functioning is an important measure of impairment, right? And what we often tend to do is think about functioning in these very bold terms. People are functioning, and then their functioning drops. And so drops in functioning are clearly very important, but drops in functioning are actually a very, very crude signal, right? So what I'd like to suggest is thinking about functioning in a slightly more detailed or sophisticated way. Again, I should emphasize this is just a model of thinking, okay? But it can be a helpful one in terms of doing your clinical evaluation and understanding a person's position. So let's say we think about the idea of some kind of mental and emotional reserve, right? Now, I had a recent discussion with a group of philosophers, and these are all difficult concepts to actually underpin, and they're difficult concepts to think about what their biological bases might be. So please bear that in mind. But if you think about the fact that we may have some kind of reserve from which we meet the cost of our day-to-day functioning, right? And in this sense, you could think about this cost as being a bit like resting metabolic rate, right? This is the amount of expenditure that you need to put in to be able to manage your daily level of functioning. And certainly in the mental, emotional, and social domains, some of the things that this will involve will be mental multitasking and planning in time, attention and concentration, decision-making, emotional processing and interaction, cognitive control, processing and navigating the world, okay? It's not an exhaustive list by any means, but it's just a broad set of areas to think about. And of course, all of these are areas that are impaired or affected in different kinds of mental conditions. Mental multitasking and planning in time are impacted in a host of conditions, and depression to psychosis to anxiety. Attention and concentration are one of the primary difficulties in ADHD, but also in depression, anxiety, decision-making in depression, anxiety, psychosis, OCD, and so on. But I just particularly highlight two things: emotional processing and interaction, and just processing and navigating the physical world. Now, these are costs that for most neurotypical people are not too onerous, but for people with ASD, very often these can be very, very significant costs in just their daily navigation of the neurotypical world. Okay, so if we think about functioning in terms of the cost that is required to maintain that functioning, then what happens as things start to get difficult is that the cost goes up. And one can look for this reasonably reliably because there are some very common indicators of cost increasing, which is that people feel quite worn out, they feel less efficient, they have less capacity for patience, they lose their confidence and start to doubt abilities that are often hardwired after many years of practice. There's less capacity for empathy, and there's less capacity for dealing with the unexpected. And this is partly because as the cost sort of increases, what people tend to do is marshal what reserve they have as best as possible to try and meet the absolutely necessary things. Often this results in life becoming increasingly regimented, and equally things that are deemed not important or sacrificable in the moment being left aside. But if there's less capacity spare, then it's much more difficult to deal with unexpected demands that fall upon you. And some of you may have the experience at times of being under incredible stress or feeling burnt out, where one additional thing just feels too much to cope with. People feel more irritable. It takes longer to recover. So you spend more time resting from the effort that you've put in as time goes on. So you spend the evenings recovering from the day, you spend the weekends recovering from the week, and you spend all weekend resting, and you come to Monday morning and you're still completely exhausted. Life tends to lose some of its spontaneity because, again, there's not enough capacity to do things that are unplanned. And people start to develop an anticipatory weariness, a dread or an anxiety, but oh God, it's Monday morning again. How am I going to get through this week? And one's time scales, the temporal perspective and the decision time scales one consider tend to shorten. So because I'm thinking about getting through this week, I just need to get through this day, I just need to get through this meeting. And one can often end up making suboptimal decisions, thinking in these very short time scales, when it would be much more prudent to make very different decisions if you could think even just a bit more longer term than you're able to at the moment. So functioning sort of starts to drop really when people can no longer meet the increased cost. So the point I want to illustrate here is that by the time functioning sort of noticeably drops, often people have been suffering for quite a long while. Another important factor to sort of bear in mind here are expectations of particular roles, where functioning cannot be allowed to drop until things are absolutely critical. And two groups that I commonly encounter this with are doctors and academics, where a hell of a lot has to have gone downhill before people are willing to say, actually, I can't do this ward round, I can't do this clinic, I can't come into work today. And that's because the expectations of those roles are so high that people will, eke out every little bit that they've got left to keep things going. So it's often a really poor indicator when one thinks, well, you're able to manage this, you're still going to work, you're still doing your ward rounds, so clearly things can't be that bad, right? When what that ends up meaning is, well, if you come to me at the point when you can no longer do those things, then I'll know things are catastrophically bad. Okay? Of course, in with mental illness, we're dealing with conditions that by and large are recurrent or chronic, though that tends to be the bulk of the people that we tend to see in secondary care services. And while this makes sense for a kind of single episode, when you're thinking about recurrent episodes of illness or chronic suffering, chronic trauma, actually over time, everything gets depleted. Okay, so in the last 10 minutes, I'm just going to talk broadly about the principles of treating mental illness. So here it's important just to sort of repeat some of the things that I've mentioned in passing already. A few important considerations that mental illnesses often tend to involve long periods of illnesses. So single episodes of illness can go on for months, okay? It is fairly common that people will have either recurrent episodes of illness or have chronic illness, which may be illness that's continuously symptomatic or illness that only has sort of partial recovery and people still continue with ongoing symptoms and difficulties, okay? All of this will have massive effects on quality of life and functioning, and they involve a considerable cost for the individual, not least a considerable opportunity cost. There are lots of things that people end up having to lose out on or give up on because their illness has intervened in life at different stages. So a common example is people who first become ill when they go to university and end up being unable to continue with their studies. And that is a massive disruption at a critical kind of developmental stage in that transition from late adolescence to early adulthood. Okay, and of course, the impact of these consequences is felt many, many years down the line, or continues to be felt. And very often illnesses can reshape people's lives and their personalities. Okay, this is just kind of a broad consideration for most mental illnesses, but it's not unique to mental illnesses, right? Most chronic illnesses will have these kind of impacts on people's lives. So just to pluck some examples out of the air, if you look at people with severe autoimmune conditions, or people with chronic pain, or people with chronic fatigue, a lot of these things will apply. So mind that those are the kind of conditions we're dealing with. The aim of treatment, very broadly, is to help people recover and rebuild or sometimes build their lives. And I specify that because a lot of the conditions we treat or look after tend to occur relatively early in life, in adolescence and early adulthood. And sometimes people may not have actually had a chance to build an adult life yet. And the task of treatment is, one of the tasks of treatment is to help them build their lives or help rebuild them if life's been disrupted by illness. And it's important to sort of hold that in mind as an overarching principle, both for yourself and for your patients. Now, in service of this aim, there will be numerous objectives like optimizing medication, helping people with past trauma, learning skills that they have missed out on. Common thing that we encounter working in early intervention services, people who become ill age 16, 17, 18, and missed out on a lot of the key developmental tasks and skills that they would have acquired during that period of their life, emerging from a long period of illness in their early 20s or late teens, having missed out on all that, as well as the time and place in life where one would have just learned those things along the way. And helping people acquire those skills is a key part of the work that we do, addressing issues around self-esteem and self-image, helping and supporting relationships, various forms of psychological therapy, and modeling, caring, and being cared for. Again, this isn't an exhaustive list. It's just some key points to sort of emphasize. The point about modeling, caring, and being cared for is particularly important for people who've grown up in adversity, in abusive families, and gone through the care system and so on, where they may have never had any positive experiences of being cared for. And it's through being cared for that we learn how to care for others in a healthy way. Okay, and these are all roles that you perform for people when you're helping them in recovering from their mental illness. Okay, so those are some broad principles. I'm going to just briefly outline some principle thinking about psychopharmacology. So it's important to remember that this is a bit of a simplistic cartoon, but we have nerve cells that are organized in brain networks that lead to various brain functions, often in a distributed, multi-component kind of way, which leads to higher cognitions and internal experiences that we then examine in terms of their presenting phenotypes, right? So this is the level that we're generally operating at clinically in terms of understanding what's going on. But our treatments are not working at that level. It is our pharmacological treatments are not working at that level. They're working here, and of course, having downstream influences on all of this. So most of the psychopharmacological agents we use are either serotonergic, noradrenergic, or dopaminergic, right? And it's important to remember that these are all sort of neuromodulatory neurotransmitters in the brain. GABA and glutamate are your primary excitatory inhibitory, the other way around, inhibitory excitatory transmitters. These are all modulators of neuronal transmission. So what I'm going to do is just illustrate this with the example of psychosis. So in psychosis, just to refresh some anatomy of the dopaminergic system in the brain, you have two nodes in the midbrain, the nigrostriatal, the substantia nigra and the ventral tegmental area of the midbrain. The substantia nigra projects into the dorsal striatum. That's the nigrostriatal tract that is disrupted in Parkinson's with cell degeneration, substantia nigra. The ventral tegmental area is the other more anterior node. And this normally projects to the mesolimbics, through this mesolimbic tract and this mesocortical tract. In psychosis, this ventral tegmental node is dysregulated, and we have a problem with excess dopamine production, which is then fed forward, particularly into the mesolimbic tract, to result in the positive symptoms of psychosis. There's also the tubular and fundibular tract, where dopamine is an inhibitory neuron to the lactotropes, and a inhibitory neurotransmitter to the lactotropes in the pituitary. So when we treat psychosis, our problem is that there's an excessive synthesis of dopamine here, right? But targeting synthesis is actually really difficult pharmacologically. So the treatments we use are dopamine antagonists. And what those antagonists do is that they essentially blockade the feed forward of this excessive dopamine here, right? So you have a postsynaptic D2 blockade that stops this excess dopamine being passed through. So how does that work? So just going back to this model I outlined, where you have predictions being passed from one level to the level below and prediction errors being passed from one to the level above. This prediction error signal is dopaminergic, right? And dopamine codes both its magnitude and its precision. So you can think about that as the peak of the curve and the standard deviation of the curve. And when you have dopamine dysregulation, this signaling goes awry. So it means that you have prediction errors fed forward into the system that may either be abnormal in magnitude or abnormal in their precision, or just abnormally signaled when they shouldn't be there, or not signaled when they should be there. But because the information going up the system is now altered, at some point the model has to sort of change to account for this new information that it's getting in. And at the very highest level, you can think about delusional beliefs as very high-level models from about the world that have had to change to account for the fact that something fundamental has changed in the experience of the world. Now, when you block that excess dopamine, what you allow to happen is you allow this prediction error signal to normalize, and for the previous model the previous predictions to reassert themselves. Okay. But it's just important to remember what you've done is you've blocked the postsynaptic effect. You haven't stopped the synthesis problem. In some people, that synthesis problem will naturally involute and it will go back to normal. In others, it'll remain active. In others, it will go back and have periods where it will continue to flare up again. And in practice, we only find this out through cautious trials of discontinuation. But if you are able to image people, and we don't do this routinely, but PET imaging, which is only really available as a research tool at the moment, has shown us that there are people who, even after a year on treatment, which is what we consider a reasonable duration of treatment, still have excessive dopamine synthesis in the ventral tegmental area. And those are people, if you were to take off the antipsychotic, the psychosis would reassert itself fairly quickly. Okay. Now, we're now getting into just thinking about specific treatments, and this section is very short because I think in terms of specific prescribing, it's something that you'll need a lot more information and experience for. So again, I'm just going to highlight some principles here. The different psychotropic medications we use, antidepressants, anti-anxiety agents, or antipsychotics, right? They're all being used to target specific mechanisms. So in psychosis, we're using dopamine antagonists to deal with that excess dopamine production problem. In depression, we're using antidepressants like the SSRIs to essentially help with changes in emotional processing that have become more negative because of amygdala hyperactivity. We're using that to change, to help restore some degree of neuronal plasticity because you see a loss of dendritic arborization that occurs in depression. Now we're using these things to see, can we achieve these effects for people? But there is a lot of variability in people's presentation, a lot of variability in terms of people's responsiveness to treatment. Some of that variability and responsiveness we can think about in terms of pharmacogenetic variation, but not all of it. So what you're trying to do is for the individual person, find a treatment that works for them. And given that many of them will go on to have either recurrent or long-term illnesses, something that's tolerable enough for them to stay on or go back on if their illness recurs. So when you're starting a trial, the questions you're thinking about are, is this medication tolerable enough for a trial? If so, is it effective enough for us to continue with a full trial? Is it effective for us to continue with a full trial? And once you've done a trial, is it effective enough to stick with, or is the person still left with persisting symptoms and difficulties? And if it is effective enough, then is it tolerable enough for longer term treatment? Most of our treatment guidelines at the moment recommend that we have people on treatment for at least 6 months, ideally a year. So you want to think of a treatment that people can stay on for that long. And ideally, if you can, a treatment they can stay on for that long without dying to come off it because it's causing intolerable weight gain or persistent sexual dysfunction, for example. Okay. So I'm just going to quickly go through the next 2 slides. What I want to really emphasize to you are some resources that you can look to get a good sense of prescribing psychiatric medications and good reviews of the evidence. And there I'd recommend the British Association of Psychopharmacology guidelines. These are consensus guidelines that have been put together by the British Association of Psychopharmacology. They're all available free on their website to download, and these guidelines are periodically updated. Another option is the Maudsley guideline, which you often have to pay for. I think it costs some 50 or 70 pounds, but those are also periodically updated and are very good. In the interest of time, I'm just going to briefly, I'm going to skip over most of this. Like I said, we're thinking about efficacy and tolerability. There are various side effects to consider. Most of the side effects are reversible once you stop treatment. So really, it's a matter of getting in early and looking at tolerability and efficacy to make changes early on to try and get something right for people. Okay, now I'm going to skip over that bit, but I'm happy to provide the slides to you.